And the other part of it is if someone's going to pop, I absolutely will not touch them until funeral home gets there, because a lot of people don't realize through the stages of decomp, their skin start to slough off. They get bloated. They don't look like really a person anymore. But if you touch them, sometimes they're so bloated, they'll actually split and
Oh,
they'll pop
stop.
and
Oh, stop. Are you
they're
serious?
just,
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey, everybody. Kevin McFarland here from the Art of Emergency Nursing. And thanks, as always, for listening to the podcast and downloading this episode. I know it's been a minute since my last episode, but I want to thank you, as always, for your support, downloading the episodes, sharing the episodes, and following us on social media. I'm on Instagram, I'm on Facebook, I'm in all the places. It was kind of a surprise to me the other day when someone told me that they didn't know I had a second podcast with Dr. Lisa Wolf. Together we do a podcast called How Not to Kill Your Patient. So if you haven't checked that out already, please do so. That one's a little bit more clinically focused, oftentimes a little bit shorter episodes, but you're absolutely going to love the podcast. If you haven't downloaded it yet, download it, subscribe to that podcast today. And as I always say, don't forget to leave a rating and review. If you haven't done so already, that really helps the podcast out. That helps other people find the podcast. And always share the episodes as well. That really helps as well. All right, let's jump into this week's episode. My guest today posted something on social media, and I just knew I had to track him down and have him as a guest on the podcast. I am so glad I did. Today, for you, I have a guest who is a nurse. He's a forensic nurse examiner and a death investigator. I was absolutely fascinated with his stories, and you will be too. So I'm going to jump right into it with this episode with my friend, Kalen Knight.
My name's Kalen Knight. I am a Forensic Examiner Program Supervisor in Omaha, Nebraska, for a hospital-based forensics nursing program. In that role, I oversee a team of 30 nurses who are specially trained in forensics. And we respond and care for victims of sexual assault, elder abuse, human trafficking, domestic violence, intimate partner violence. And we also coordinate a few workplace safety programs, such as like domestic violence that colleagues are going through. I support colleagues in that instance while they're at work. And then we also respond house-wide to both of our facilities in Omaha. And we also offer telesane services to rural community hospitals that don't have access to forensics examiners. And we kind of help support those forensic services for those populations. So that's my primary role. I also work as a medical examiner investigator. That's what they're called in my jurisdiction, but you'll hear them called a lot of different things across the United States. So there's death investigator, medical legal death investigator, nurse coroner, deputy coroner. There's a variety of different names. But I do between 5 and 15 call shifts a month, typically for that role, in addition to my primary job. And in that role, I respond to all deaths that occur outside of the hospital within my county. So natural, suicide, homicide, accident, not sure. And then we also do investigations for any deaths that occur in the hospital within 24 hours of admission.
Nice. Now, that seems to be a little bit of a unique role. I haven't heard of a lot of nurses who are in that kind of coroner role or medical investigator role. Is that a newer thing? Is that something that's more common, or?
I think it's definitely newer. It really varies jurisdiction by jurisdiction. So there's the coroner system in some states and the medical examiner in other states. And then some states actually have a mix from county to county. So for example, in my state, Nebraska, we just have the coroner that falls to the district attorney's office. So then there isn't an elected role for a coroner, and the death investigation is actually just done by the law enforcement agencies where that jurisdiction falls. So there's not an actual role to be a death investigator in my state. But I always wanted to be a death investigator, always fascinated me. My original career that I was going to go into was forensic science. I actually did tour a campus for a program for forensic science. One of the professors found out I wanted to stay in Nebraska, and they told me, well, if you want to stay in Nebraska, find a new career, because it was going to be really hard to find a forensics job in my state. So my sister's a nurse. She convinced me to go to nursing school. I shadowed her while she was staffing one night. Absolutely loved it. Saw a rapid response, and I was like, okay, this is for me. I like the adrenaline. So that's how I got into nursing. But then when it came to being a death investigator, I found out Iowa, just across the river from Omaha in Potawatomi County, they have the medical examiner system where they hire death investigators. And in our county, you don't have to be a nurse to do it. There's a variety of different individuals from multiple backgrounds who do the role that I do. And then we just all receive the same training through a death investigation course where we traveled to Missouri for a course. There's a variety of courses offered throughout the nation. But then there are some jurisdictions that require you to either be a police officer, work in EMS, be a nurse, or absolutely have no training and you just kind of learn on the job.
Interesting. I know in my old community, I know we had people who did the folks that worked for the medical investigators. A lot of the folks were, uh, biology grads. Like they had a degree in biology, and that was about it. Um, it seems like it would make a lot more sense to have a nurse there who's someone who's a little bit more specialized with, health and life, and then can then bring that to the death investigation piece as well. It seems like they'd be a better fit than, just not, I don't want to sound terrible, but like someone that has no medical training at all.
It
So,
definitely, I can definitely tell from like my time going onto death scenes how quicker I can work through a certain investigation when I do see something that appears to be a natural death. I can look through the medicine cabinet and I recognize what these meds are. I know what they're for. We have to count all the medications on scene. I can examine a decedent's body and I can see the swollen feet. I can see the med. I'm like, well, we have a congestive heart failure patient. Where's their medical records? Who's their primary care? I can request that information to figure out, are they doing their follow-ups? I feel like having that nursing background definitely helps bridge the gaps in the health knowledge because a majority of the deaths I go to are going to be natural deaths. I just have to figure out if there's anything suspicious or unexplained about it to where do we need an autopsy or do I find enough to report off to my medical examiner where they feel comfortable saying, okay, I feel good releasing this and not doing an autopsy. I also think that being a ER nurse definitely benefited me in my transition into this type of role because one, we see the trauma, we see death quite a bit in our setting. So I feel like I naturally was able to go into that role. And, we all have that nurse load. When you're at work, you do what you need to do to protect the patient. When I'm in my death role, it's easy for me to shut up and be like, I'm here to do an investigation and figure out what's going on. So I definitely think being a nurse helps.
now how long have you been a nurse?
So I graduated in 2016 from nursing school, and I actually started in the emergency department. So all through nursing school, I worked as an emergency services technician in our level 1 trauma center. I also worked for our biocontainment unit. I started while we had our Ebola activations. So I had the opportunity to care for Ebola patients when I was a tech. I graduated nursing school, and then I did a fellowship program for the emergency department. After being a nurse in the emergency department for 3 years, I was also a nurse for the biocontainment unit during that time. And at the end of 3 years, I then applied and became the nursing professional development specialist for the emergency department at our level 1 trauma center. So I did that for about 2.5 years before this opportunity came forward for the Forensic Examiner Program. And I'd actually looked at becoming a SANE nurse earlier on in my career. And at the time, being a male, it wasn't really supported. And there wasn't a lot of support to allow me to do that in our region. But that changed as we got new leadership and as new people started taking on the program. Because it was kind of an unofficial program in my hospital. Like there was just nurses who were passionate about providing those cares. And then they supported me getting the training. The job came open and I applied and I was able to get that. So that's how I got to where I'm at. I also have a background working for the NETEC. I'm not sure if you're familiar. It's National Emerging Special Pathogens Treating and Education Center. So we did a lot of traveling there, traveling to long-term care facilities and other hospitals to kind of evaluate infection control prevention processes and procedures at facilities.
Very
So
cool.
I've really primarily had my focus in emergency, infectious disease, and education, and now
Nice.
forensics.
Now now is there a difference in the program where you work? So in my mind, when I think of forensic nurses, because most of the forensic nurses I've worked with have been more focused on the sexual assault piece. Is there a differentiation where you work between the forensics and the sexual assault piece, or are they one and the same?
So they're good. I'm working to get them to really be one and the same. In my facility, I want my organization, and I have a lot of support in my organization, so I'm very fortunate. I want an all-encompassing forensics examiner program. So, like you had mentioned, it's historically been focused on sexual assault nurse examination, and that's what we started. And now we're working to expand to respond to all domestic violence, all intimate partner violence. And we don't want it to be a call us, we'll tell you what resources to offer the patient. We want the patients to actually know that someone's coming in because of the situation they're in to support them. So that's kind of what we're moving towards. So right now, we do respond to all sexual assault adults because we have a child advocacy center in our region. That's excellent. Domestic violence, intimate partner violence, human trafficking, elder abuse. And then we're going to be working towards physical assaults in the future as well, if they haven't yet been reported and they haven't had forensics photography completed of injuries. And then I'm actually working on a pilot project that in the early works, but what we're trying to do is partner with our county to where our sexual assault nurse examiners, when there is a homicide in the community, that sexual assault is potentially suspected to have occurred, our nurses can be dispatched to the scene and cut evidence on scene before a body is actually transported to the morgue. Because depending on how long they've been dead and the transport, there's a chance of losing evidence. So we're hoping to eliminate that. So my goal as a program supervisor is to try to expand it and become an all-encompassing program.
Very cool. That actually sounds like a big job to try to kind of unify those two different worlds that are separate. Because yeah, when you mentioned forensics, immediately I went to the sexual assault, and I could see where being a guy, and this isn't to sound sexist or anything, but being a guy is maybe, for some it's not going to matter at all, but for some it may be a little bit of a challenge. So you mentioned that kind of stigma of, okay, you're a guy, you wouldn't fit here, but the reality is like, as long as you know what you're doing, you know what you're doing.
Yeah. And I was honestly, I had my own bias against myself when I originally thought about doing it because I'm like, I knew it was interesting to me. I had one lecture on it in nursing school about forensics nursing. It was like one day,
Yeah.
hour of the day actually, learning about it. I was like, oh, that sounds really interesting. So then when I graduated, worked in the emergency department, met some nurses who were doing it. I said I was interested. There was a few that were supportive, and then there were a few that said, we really don't think that this is a field for male nurses. So I just kind of said, okay, I guess I can see where you're coming from. I'll stop from there. Well, there was one incident later, a few years later, where a patient had requested a male nurse, and they didn't have one to offer. So then it kind of opened the door. I'm like, well, I was originally interested in this. I'd love to do it. So they paid for my training. I traveled up to Minnesota for some clinical skills labs, got trained. And in my experience, since being a forensics nurse, I've never had a patient turn me away. I would say the way I like to go about it is one, when I introduce myself, I don't introduce myself as a sexual assault nurse examiner. I don't say I'm a forensics nurse. I just say I'm a nurse that works here at this facility, and I'd like to sit with you and talk to you about your options while you're here. And then I give them the options. I build a rapport, and then I kind of move into what their options are. And then once they've selected it, I ask them, do you feel comfortable? I'm the one that fulfills those tasks. And I've
Yeah.
never had a patient tell me no.
Yeah. It's kind of funny. I remember as a nursing student going to my OB rotations, and I remember people being like, "Oh, scoot along, you're a guy, you don't belong in here." But yeah, it's kind of funny that you'd think that as a nurse, but the reality is most of the physicians are males, and
I
that
always
and
think
nobody
that
and nobody bats an eyelash at that. Like, that's not a big deal. But yet for the nurse to be, it's one of those just kind of weirdness that I don't know, if we'll ever get through. And certainly there are some people who break the mold. I mean, where the place where I did my OB rotation as a nursing student had a male nurse. And, I asked one of the other nurses, I go, well, how's that work? Like, does that, like, are people okay with that? Are they good with that? And they're like, oh, the women love him. Um, and they're like, he's amazing. And he was like, he was great. I mean, he did a great job, and he absolutely knew his stuff. He was an absolute expert. And there may have been some people who were uncomfortable with that, but for the most part, I think people were just like, whatever. So
Yeah. Well, and I feel like half my battle, and I try to address the elephant in the room pretty early. I'm like, I realize I'm a male, and I do realize what you're here for today. And I want you to know that regardless, I'm here to care for you. And I want to know if you're comfortable with that, or if you want me to see if I can find someone else. I try to be as real with the patient as possible. And kind of going back to what you just said with most OB doctors being male, that was something that pissed me off when I started. And I was really interested because I'm working in the emergency department. And all day I'm like, oh, I have a patient who has a male physician that needs a pelvic setup. I need a female chaperone to go in with them. No one bats an eye. And I'm like, that's the most invasive part of my exam. And no one cares if male residents are going in there and doing it. And I'm like, I'm doing the exact same thing. I'm just spending a little bit longer building rapport and talking with them. There's no reason I couldn't do it. So
yeah,
now that I look back at myself, I wish I would have fought harder. And I'm like, no, I'm not going to take no for an answer.
yeah,
But I definitely got enough experience after being told early in my career, no. Getting my experience as an ER nurse, I was a better forensics nurse when I was given the opportunity.
Yeah, I remember as a tech, I also was a tech before I started as a nurse in the ER. And I remember, we had our gyne rooms, and the gyne rooms, the doctors would come out and say, "Hey, I need a chaperone." And I was always like, "Not me, not it. It ain't gonna be me." And then one of the female docs is like, "You can absolutely be the chaperone." She's like, "We just need one woman in the room, and that's gonna be me. So come on, let's go." And then the truth of the matter was that I had no idea what to do in there. So like she was
Uh-huh.
like, yeah, the reality was as many times as I walked through people through the process, like I didn't know how the steps went. I didn't know how it actually happened. Um, and, just because it was just something I hadn't been involved in. And that doctor was like, "Nope, nope, just need one female in the room, and that's gonna be me. So it doesn't matter for you." But yeah. And the reality is, when she asked the patient, she said, "Are you comfortable if he assists?" And the patient was like, "Yeah, I don't care." So
That's really how most of them go. I feel like people want to make a bigger deal out of it than it is. When as a community population now, I don't feel like while it's in the news and it's political a lot, gender is always talked about. I feel like in my
always.
actual practice as a nurse, it's not that big of a deal. People don't bat an eye at a male nurse walking in a room anymore. Or I feel like it's getting better where like early in my career as a tech, I remember having some more elder patients come through who'd be like, I'd really only prefer females in my room. And that would happen really early in my career when I started in healthcare, but I haven't seen that happen in years now.
Yeah, I've always been the nurse. I'm like, "Yeah, if you prefer a female, we'll get you one. That's not a big deal. Like I'm just here, I'm just here to take care of you. And either it will be me or it'll be someone on my team who's equally qualified, and that'll be just fine." It's one of those things I think most folks don't really take personally. They just understand. They're like, "That's fine. It's not a big deal."
Yeah. It's
So
not worth stressing over because it's not about you, it's just about
yeah,
their
yeah.
yeah.
And we had in my role now as an admin soup, as a house supervisor, we had a patient who requested to not have a male nurse. And I was like, "That's fine." She was originally given a male nurse as a assignment, and I just switched him, and he was really offended. And he was like, "Wow, what does she think? I can't take care of her, this and that." And I was like, "It's not about you. Like, it's not about you, and it's not a big deal. I mean, let's just switch it and do what we can to make the patient feel as comfortable as we can, because that's how we take the best care of them." And
Yes,
yeah, just
exactly.
had to keep reminding him, like, it's not about you. And it would have been any anyone with a penis who she would have not been
Yeah.
comfortable with. And that's certainly her right to say, "Hey, I'd prefer this." And okay, we'll try to accommodate. Now, there was a day also in the emergency department where I looked around, like going, "There's only one female in this building right now." And we're like, yeah, there's times that, sometimes maybe it's not available. And if that's the case, then you do what you got to do. But
Yeah.
well, interesting. Interesting the kind of potential of gender bias being there for the care. So
Yeah.
kind of interesting.
And I'm excited because I'm gonna be going to the IFN conference this, upcoming September it is. So I'm a director at large for the IFN on their board of directors, and I'm
Nice.
gonna be presenting with another nurse talking about, practicing while other is what we're gonna discuss as a presentation, talking to it as a male, talking to it as a gay male, and then she'll be talking about it's her second career. She was a lawyer first. She's kind of talking about how we don't fit the mold of our normal what a normal forensics nurse looks like. So I'm excited to talk more on that because the people that want to listen, that's happening. We're getting to a point where people want to hear about it. So that's exciting.
Yeah, that's
I'd
cool.
love I'd love to see more male nurses enter forensics.
Yeah, yeah. I think it's a place where there's probably fewer male nurses than most other um places, and I get it, but also the guys would have a lot to offer there too. I want to spend a little time talking about the death investigator piece and that role that you do there, because that's something again that I haven't heard of much is nurses working in that role. How did you end up, getting into that? You mentioned that it was an interest before you went to nursing school. How did you circle back and find that they hired nurses and get involved?
Yeah, so I actually, in my emergency department, I worked with a nurse who her first career was forensic science. She got her master's in forensic sciences when was working as a crime scene technician for the law enforcement agency in my jurisdiction. And then she ended up going back to nursing school and becoming a nurse and working with me in the emergency department. And she was working as a death investigator for a county in Iowa while she was working in the emergency department with me. And I just overheard her talking to someone about how she was on call as a death investigator that night. And I was like, hold up, what is that? Like, I want to hear more because that's what I wanted to do. And she's like, oh, yeah, anyone can apply. They had 3 positions open at the time. It was just the right place, the right time. I talked to her about it. I was fortunate that she felt comfortable putting in a good word for me. And I interviewed and then got offered the same job same day. And I started the following week.
That's cool.
But I was very fortunate to have it. And like I had mentioned earlier, it's every jurisdiction varies on who's allowed to do the role. So I hope to see more systems adopt medical examiner systems, or at least death investigator roles within coroner systems. I tend to see when I do my actual research on what jobs are out there, most of them appear to be medical examiner systems as opposed to coroner systems.
Okay.
But I have seen some deputy coroners who are death investigators.
Now, how does that pay compare to like your typical nursing role? Is the pay comparable? Now, I would imagine that because they have that broad spectrum of people they hire, that it may not be.
No, it's definitely a job you do because you want to do it, not for the money. So I would do the job full time if I could, but I cannot make a living off of what you make as a death investigator. So we have a flat pay. Everyone's paid the exact same in our department. There's no like appraisals, there's no raises as your career goes. And we're paid like a minimum. I want to say it's $2.50 an hour, I think, while we're on call. And that's paid out quarterly to us. And then when we get called in, we're just paid our base pay, which is around, I'd say it's about $25 an hour. And for a phone investigation, we're always going to be paid for 2 hours, no matter what, even if the call doesn't take us that long. And then for a scene investigation, we're paid for 4 hours, no matter what.
Yeah.
And then if we go over, we're paid whatever, however long we're there.
Yeah. So it sounds like I mean, the pay may not be great, but it's
It's
not
not terrible.
bad.
Not
Yeah.
bad. It's the challenge comes that it's just a casual job. So you can't do it like for full time 40 hours a week. We have one chief investigator. So she covers all call Monday through Friday. And then the remainder of us, I want to say there's 8 or 9 of us in my jurisdiction now. We split the nights and the weekends. And our
Nice.
call shifts are between 12 and 14 hours, depending on the weekday.
And about how often do you get calls? Like, is it no, you're going to be up all night kind of thing, or?
It varies. So I have gone 3 months without a call on any of my shifts. And I would say I average about 8 call shifts now a month. I've gone 3 months where I was just a white cloud and got nothing. And there's 3 weeks back, I got 4 calls in one shift. And I was like, oh my God, the reports I'm going to have to write tonight. And when they're autopsy cases, I have to do them immediately because the forensics pathologist needs it when they do the autopsy. And if it's like a high profile homicide or a very suspicious suicide, they'll probably move that autopsy up. So I'll have to get it in. So when I get home and I only do night calls since I'm a day hour worker at the hospital, I'll get off a call and get home at 2:30 in the morning and I'm writing a report until 4 in the morning, emailing it over, showering, getting up and going to my day job.
Yeah. Now, do you get paid while you're sitting at home writing your reports? Do you get paid for that time as well, or is it like considered part of the investigation? But
It does count. So that if most of them, I would say a majority of my calls, I manage to get off scene within 4 hours. I can do a thorough investigation. The long ones are the suspicious suicides we're on, or the homicides that we're on for quite a while.
what exactly does a death investigation look like? Tell me like an average. You go on scene. There's a suspicious death. What does your role entail?
Yeah. So when I am on call, anytime that an officer comes across, like there's a decedent on a scene, whatever the circumstance, they notify our dispatch calls us and they give us just a rundown, the address, the lead law enforcement officer on scene, how many decedents we're dealing with, and if it's inside or outside. So we can make sure we bring the correct gear. From there, I'll drive to the scene, do the whole scene safety thing with the law enforcement officer. So they'll let me know any concerns. So animals, if there's an unsecured weapon still, because they can't touch weapons until we've been to the scene and taken photographs. So I'll get there. I'll do my initial scene walkthrough just to kind of get an idea, stem some thoughts that I want to ask in my interviews. And then I will gather details from the law enforcement officer. I'll gather details from any witnesses. And then I will gather details from the next of kin and just kind of get a medical history, get as much as I can from them. Once I've completed my interviews, then I go back into my scene and I'm actually working through taking my photographs of the scene, and then I'm taking my photographs of the decedent, assessing any injuries. And it's very different in my role as a death investigator compared to a forensics nurse. Because as a nurse, we want to document abrasions, lacerations, the size, the color, the drainage. We do not identify or diagnose anything as a death investigator. It's just called a defect. So we'll note a defect to the anterior left chest. Whereas a nurse who's seen a lot of gunshot patients come through, I may look at that and say, that's the entry wound and that's the exit wound. I can just tell that, but I never do that as a death investigator because I'm leaving that to the job of the forensics pathologist.
Yeah.
So I take photographs. If it's not an autopsy case, I'm going to do fingerprints and collect DNA swab. If it is an autopsy case, then I have to make a few extra phone calls to coordinate funeral home, the forensics lab. I bag the hands, put toe tags on, package them up for chief of custody, and I stay with the body until funeral home picks them up. And then once I'm done on scene, then I go home and I will write a report. We use the software for my jurisdiction where we can fill in basically all the demographics information. Then I have a few narratives. So I have a history narrative, a scene narrative, and a body narrative. And then that all goes to the pathologist with my photos.
Nice. Very cool. What an interesting job. How interesting is that?
It's as morbid as it sounds. I'm just a morbid individual. That kind of stuff interests me. I love the job. So
It's kind of funny. I think every ER nurse out there is kind of like this in that you see something horrible and you're like, huh, it's kind of interesting. Where my wife, who's not medical at all, would be like, oh my God, this is like, I can't believe I'm seeing this. And I'm kind of like, oh, that's kind of interesting.
Exactly. My husband doesn't even want to hear me talk about it. He's like, your job's your job. So I actually convinced a colleague of mine at my hospital. She's an EMT that works as the admin assistant for us. I was like, hey, you'd be awesome at this. Want to do this? So she applied. She got the job. And I was like, I have someone to talk about my morbid stuff with, finally.
Yeah. There's, I always laugh. And there's days that I would come home and I could tell my wife about what happened at work. And then there are other days it's like, you don't want to know anything about today. You just don't want to know. So,
and half of my husband's problems are like, so, I mean, a majority of our deaths that we go on, I won't lie, their houses are not always clean. You go into some really bad houses, especially if you've ever worked EMS or you're familiar with that, you know what houses look like. So when you add dirty houses and someone who's been dead a week and not found who's decomposing, and there's bugs present, where there's times where I come home and he always texts me like, let me know if it's a bad one. Because if it's a bad one, he meets me at the door, makes me strip right there and walk straight to the shower. Because he was like, you were not bringing any of that in here.
You're like, just take it all off right there. Like this. You're in the garage stripping down. I understand. Yep. Had plenty of those shifts too, where I was like, I just need a shower. That's all I need today. Been there, done that. So what an interesting job. What a cool job to be able to do that. That's, just something different than your average, nursing job. So
it is. It's very interesting. It allowed me to think critically in a whole other way. Like I'm going through and I get to actually look for detail, find puzzles that don't make sense. Like it's fascinating. Something I never realized is I assumed that when I applied, I assumed most of the deaths that we went to were just natural deaths. But no, when we're death investigators in our jurisdiction, we respond to everything. So if it happened outside the hospital and they're not on hospice, we go. So car accident, an accidental fall, gunshot, stabbing, hanging, all of that. We see all of it. So it's definitely allows you to see things through a unique lens.
Yeah, for sure. For sure. Like, boy, I'm sure there's days that, by the end of the week, you probably need some serious therapy. You're like, oh man.
It was a week. And one other just random fun fact that I just think I never expected is most people die naked. I don't know why.
Why is that?
Most of my people are naked when they die, even if it's not related to how they died. I just don't get it. That's something I learned as a death investigator. I went through orientation. I had the black cloud in my death investigator orientation. I still like one of everything, which was awesome. And then I get off of orientation. I'm going through months of training, and I always go back and I review prior cases that are similar to the ones I just had to see what they highlighted and what they investigated. And I look at photos from previous cases. I'm like, it just clicks. I'm like, everyone is naked or at least half naked in all of these photos. And it's just a weird fact about being a death investigator that it's just weird. I don't know why it is.
That is weird. Now I've certainly heard that about people who are exposed to the cold, that, when they die from cold injury, that oftentimes as it gets close to the end, they feel like they're hot. So they're like stripping off their clothes.
Yeah.
You're like going, why is this naked dude sitting here in the snow? Um, and it's because they felt hot. They stripped off all their clothes and sure enough they're, you know, now butt naked and dead. But that's kind of weird that that people would be like naked dead. I don't
It's
understand that.
it's it's so weird. I don't know. But actually, you just mentioned the paradoxical undressing. I've seen that on multiple death scenes, and that's something that as a nurse helped me when I'm on a scene. I've been on motor vehicle collision scene before that was found about a day later. Someone struck a tree. And there was a suspected, like, well, is this a sexual assault? Did someone find them? Like, what is this? And I said, oh, well, let's look up what was the weather last night. We're looking at the weather. I'm like, no, this is what was happening. So now I can tell you right now, he wasn't dead on impact. He, like, this is what happened. So
Yeah.
that's the side of nursing that's really good to be able to bring into it because I know that background that some people may not know until they actually experience it and get educated on it.
Yeah. Give me an example of a case where your nursing background kind of played into helping you kind of get some information on the case. Can you give me a can you give me a couple examples?
Yeah. So I would say that they're the most helpful on my natural death cases where when I go in and law enforcement or CSI, if they're there, are looking at a case and they're like, this just doesn't seem right to me. So two example, a big one is cardiac history. So like when I go in and I can find, I'll look through all their meds, I'll do the assessment on their body, look for telltale signs of heart failure, look for any signs of, okay, are they diabetes? Are they doing their injections? I'll look in their fridge, look for insulin. Um, just knowing where to look based off their medical history. And then when knowing where to look in their home to actually find something relative to who their primary care provider is. Cause a lot of time that's all I need. If I can get their records, I can make a decision really quick and report that off to my medical examiner. And our medical examiner is an emergency physician, was his background. So we're able to kind of converse about what we think is going on. So sometimes I'll have cases where someone has bruising in odd spots where law enforcement's like, well, is this an assault? We don't know. And I was like, no, this is their insulin injections. And I know that because here's their primary care provider they see for endocrinologists. Here's their insulin in the fridge. There's an open glucometer right here. Like, this is what's going on. That looks like bruising that I see in the emergency
But
department.
that's like an example of something that like as a nurse you would spot, but as a non-nurse, like a non-nurse may not pick any of that up.
No. Yeah. So if you don't know what you're looking for or you don't know what you're looking at, it's going to be really hard to do this role. And that's why it's a lot of on the job training. So our chief investigator is great. She makes sure that people don't come off until they're ready. And then we all go through the exact same course. So we get the same information. So our training is that there's a basic course that's a week long that we do down in Missouri. And then at 3 years, there is an advanced course that we take as well. But she also sends us to trainings all the time. We're very fortunate. So there's fire death investigation ones where they'll actually put cadavers in a fire and then have us go and investigate the crime scene of the fire.
Interesting.
And then it's just seeking out all those additional trainings. But I would have struggled a lot if it wasn't for my nursing background when I first became a death investigator. And that's not to say anything against my colleagues that do it that aren't nurses. They still do a great job. I think I'm fortunate that I'm able to go through scenes quicker and identify things fast because of my experience, where you have to put a little bit more effort in if you're not a nurse or healthcare worker.
Absolutely. Absolutely. Yeah, it seems like that'd be a great advantage to having that background, having that
Absolutely.
nursing
And
background.
other cases I've seen, like there's been cases where I wasn't working as a death investigator, but I was working in my nursing role where I've been consulted as a forensics examiner just to come look at a patient who's intubated and the nurse finds something that just seems off. Where if it wasn't for a nurse identifying it, a case would have gone unsolved. Where there's been cases I've seen where a sexual assault occurred before death and it was a medical death, but we found evidence of a sexual assault and the case went in the right direction. So that's just another example of as a nurse, we look through a lens differently where we're not just looking at what we're told. We don't have that tunnel vision when we arrive on scene and law enforcement tells us this is what it looks like. I'll say, okay, thank you. I'll do my own investigation. Sometimes my outcome is the exact same as theirs. I just want to find that outcome myself. And I've had other ones where it is not the same. I've had a death in the past where I went on scene. My first red flag is it was a younger person. So whenever a younger person passes away, while there are congenital items, I'm already a little bit suspicious. Well, I go on scene. I'm told the time frame. I assess the body. I'm like, I can tell you right now, this is not when that person died. I'm looking at their rigor mortis, livor mortis, stage of decomposition. The body's cold. I'm being told that this was done. I can tell you by their position and their rigor that was not done. So that's another benefit as a nurse that helps. I have a better understanding of identifying
For sure.
what it looks like. Even though you can't tell time of death, everyone thinks, well, what time did they die? I'm like, I can't tell you that. No one can tell you that. If they do, they're lying.
Come on, man. Come on, Kalen. They always make it look so easy on TV. I used to watch this TV show all the time and be like, oh yeah, time of death was probably about 8 o'clock last night. And you're like going, how would you know that?
Every single time it happens on a show, I dart my eyes over to my husband. He puts his hand up. He's like, stop. It's a show. I don't want to hear it. And then I would sit back mad because that's not
Every
how it works.
every ER nurse on the planet has
Yes.
experienced that. Like even today, like we were watching a show and I was like, that's not really how that happens. Like it doesn't like just happen that fast. And my wife's like, I know, don't. Because my wife's not medical. She's like, I know, don't care, don't care.
That's on my husband. He's like, I don't want to hear it. Suffer in silence.
Right? Him and my wife probably get along just fine. Is he in the medical field?
He's not. He's financial crimes. So that's what he
Okay,
focuses on in banking.
okay,
Yeah.
all right.
So
Doesn't
even though
seem
he does investigation, he's like, I don't want to hear about your investigation. I'll stick with my data analysis and figuring out if people are doing suspicious money laundering.
yeah, and God bless him for doing it, but this just doesn't sound near as interesting, right?
That's how I
Like
am.
no, not interested in that at all.
I'm happy he loves it, and I'll stick
Yeah,
with my
no,
decomposing bodies in the corner.
yeah, I'm glad there's people out there who can do that. I'm just glad I'm not the one who has to. So
Like that.
have you had a time in your nursing career where, you've kind of brought those skills and said, okay, oh, hey, based on this other experience I have, this might kind of lean us more towards this way or that way. Either when you were working in the ER or maybe it's just in your forensic. You mentioned, being called to look at stuff when you were just working as a forensic nurse.
Yeah, so we offer general forensics consultations in our program. Whenever a provider or any role will take a consult from anyone, just feels like something's off, even if they haven't maybe asked the patient or talked to the patient about it. My general recommendation is if you suspect something that could be related to a crime, call us first, because if you don't want to be the one to have that conversation with them, especially since your care is going to be ongoing and you don't want to ruin a relationship you've had with the patient, our team will come in and we'll have that conversation. And we
That's
often can do it in a way that we're not saying, oh, we were called here because your nurse thinks you're being trafficked. No, I'm coming here because I just like to check in on every patient once they're admitted to see how things are going for them, if they feel safe at home, if there's any resources you could use in your community. And we do our own assessments that way. And in my experiences as a ER nurse, and as a sexual assault nurse examiner in the emergency department, seeing different patterns of injury and different assaults, and then going up and doing assessments and hearing people's stories without doing an assessment, just making visual observations as I'm talking to them. Sometimes I'll note things that I'm like, okay, well, I do have my suspicions that this is happening. But at the same time, where people go wrong who are trained in forensics is they will make a report. And sometimes you can't make a report based off your jurisdiction, your state statute. And sometimes making a report is also not the safest thing for a patient. So then we offer resources in a way to where the patient's aware of what is available to them. But if they're not ready to take them, they don't have to.
yeah.
And before there were forensics nurses that were able to fill that gap, people would see this, suspect this, and call law enforcement. And then OPD or a law enforcement agency would show up to the patient's room and be like, we were called for the suspicion, and the patient's caught off guard.
And it just changes the whole dynamic, right? Like
Always.
when,
Yes.
someone with a badge and a gun shows up and it's just going to change. Just it just has to, it just changes the dynamic a lot of times, pretty considerably.
Yes. And I always tell people, like, when you're learning, even though it feels like the right thing to do is to get them help and send the advocate or send the law enforcement officer right now, if they're not ready for that, you're breaking their trust, not only in you, but in the healthcare system. So when they do need help in the future, they're not going to feel comfortable coming to us. So I always tell everyone we're playing the long game. We're assessing them. We're making documentation of what we saw. We're offering them those resources so they know it's there. And then if it's not a mandatory report and they don't want us to report, then we're not going to, and they know that where they can come when they're ready.
Yeah. Yeah. I like that. I think it's a good thing because sometimes oftentimes someone shows up in law enforcement, it just changes the whole dynamic.
It does. Well, even on my death scenes, when I'm doing interviews with witnesses and next of kin, sometimes there's times where I need to know information to figure out what could have happened, but sometimes the family or the witnesses don't want to share it. because law enforcement's there and they're afraid it's going to get them in trouble. So like if there's maybe drugs associated with it, I want law enforcement to sometimes step away. I'm like, hey, I'm going to do my interview. I'll call you over if I need you. But sometimes I can tell people are withholding information from me, and I need that information to make a solid judgment on autopsy or no autopsy with the medical examiner. So there's definitely two roads. Sometimes it's nice. Sometimes I need them away.
Yeah. Yeah. No, for sure. I understand that for sure. So what a cool, interesting job. Holy cow. That's
Yeah, I
neat.
definitely, I definitely think if there's people that are interested in doing it, there's a lot of training opportunities out there to seek out. So through, I think St. Louis University, they have a death investigator training. I know of one in Des Moines, Iowa. There's a few masters in forensics programs. I do adjunct lecturing through Oakland University's program. So they have a death investigation course up there. There's a lot of trainings out there. So I think if there's someone that's interested in doing it, definitely seek out those trainings. And then as far as job shadowing, it's not easy to shadow a death investigator just because of if there's an actual crime and there's evidence on scene.
Yeah.
But to find out if it is for you, you can usually get into your local morgue for autopsy shadowing. So I encourage people to reach out to see one, if you can watch an autopsy on someone who is decomposing, you can find out if you can handle the smell. That's the
Uh,
first step. That was my number one fear.
oh, so when a long time ago when I worked as a tech in the ER, we had our medical investigator was kind of close to our emergency department, not real close, but kind of close. And we usually had a company that would come pick them up from the ER and take them over, across the street to the medical investigator's office. But we had a really big patient, and for a really big patient, they didn't have the capacity in their truck and their gurney, so we ended up walking the patient over and got a chance to put the patient in the decomp freezer. And I'll never, to this day, I'll never ever forget that smell. And like I couldn't get that smell out of my nose the
No,
rest
it
of the
sticks
night.
on
Like
you.
I remember going in there and the guy who usually delivered the bodies went with us and he walked over there with us, which he didn't need to do, but he was kind enough to do. He's like, well, let me show you how, because I'm usually the one doing this. So let me show you how this will go down. Um, and he stopped and he said, no, you just need to know. Like, you might see some stuff in here, but you're definitely going to smell some stuff in here. So just be ready. And he opened it because it was the freezer for the decomps and the extra large bodies. And we had the extra large body there that we were taking in. And I'll never forget, he opened up that door and just the smell, like I'll never, ever in my life forget that smell.
No, it's interesting I'm able to do this job because I'm notoriously known in my facility as probably the weakest stomach nurse. So there was one period where we had 19 nurses pregnant at the same time in my facility. So when they were throwing up, I was empathetically throwing up with them. So that was a problem. But I've thrown up on pretty much every unit in my hospital between C. diff, vomit, mucus, whatever it be. Smells, I just can't handle. So I had very large concerns going into being a death investigator, but I wanted to do it so bad I hid my vomiting like feelings at the beginning and until I could figure out a way to be able to handle it on scene. I've gotten better, but I tell everyone if you can't handle smells, you can do this job. So I just have to wear my N95 masks. I have peppermint drops that I drop into my mask, and it sort of masks the smell enough for me to handle it. Um, but I can't drink any peppermint drinks anymore. Like I associate peppermint with death, so that's kind of ruined my winter peppermint mocha. I also learned a few tips when I'm on death scenes to prevent the smells from happening. Like typically, I won't touch anyone or touch any body until the funeral home gets there and we're putting them in the bag. Because once you move the body, that's when the bacteria, that's when the smells come out. So usually I can avoid having to smell anything towards the end. And the other part of it is if someone's going to pop, I absolutely will not touch them until funeral home gets there because a lot of people don't realize through the stages of decomp, their skin start to slough off. They get bloated. They don't look like really a person anymore. But if you touch them, sometimes they're so bloated, they'll actually split and
Oh,
they'll pop
stop.
and all,
Oh,
and
stop. Are you
their
serious?
juices, yeah, their juices will come out. And that's the really bad smell. So that's the
God.
types of things to think about before going down the road of being a death investigator. Because not everybody decomposed, but I have had some gnarly cases in my time, especially in the summertime. People found outside or in cars in hot weather, like, and then you bring bugs into it. Or sometimes if we don't know how long someone's been dead, we'll bring an entomologist in to kind of look at the bugs on the scene, get a time frame. And sometimes it's just larvae and maggots that are on a body, and getting pictures of that, trying not to get them on me, getting them packaged up with the body so people can see that it was
Oof.
there. Very interesting work that I do.
Yeah, that doesn't sound appealing at all. Holy cow.
Not all of the cases are that bad, though. Not all of them.
That's good. That's good. Holy cow. It sounds like that can get pretty gnarly.
It can. It definitely can. Some cases are bad. Oh, and that's the other thing is sometimes on scene that helps me having better nurse and have that therapeutic communication with patients that helped me be able to talk to families when they find a loved one who has passed away and interviewing them. Like that's a whole another side of being a death investigator that people struggle with is talking to people who just either found their loved one dead or just found out their loved one is dead.
That's
It's
that's gotta be
it's
one of the
hard.
hardest parts because in my current role now, I often get to be the bearer of bad news and be the one who kinda is the go-between and, like, the communications with the family, and boy, those are sometimes some really hard, awkward conversations to have.
It
So, I
is.
can't imagine, like, because you think about it, a lot of these folks that end up getting found are typically found by loved ones.
Yeah, usually.
Not uncommon. Like,
No.
that's probably, probably the most common, that they're gonna be found by their loved ones, and that's boy, what a terrible thing to
Yeah, and then
it's
trying to do our interview in that moment with them when they just saw that, and if they haven't been seen in a while and they don't look like them anymore, and then doing my interview, it can be very hard to navigate that, so having to be patient, knowing the right things to say because of my experience as a nurse are helpful.
yeah,
Um, yeah, so that's definitely another benefit of being a nurse going into this field.
yeah, I bet that piece is, for a lot of people, that's the hard piece is, communicating with the families. I work with a doc who's fantastic in a recess, but boy, you get him in front of the family and he just folds like a yeah, he just folds. He just has a really tough time and doesn't know what to say and really struggles.
Yeah,
Um, when, during the code, he's, Johnny on the spot, great, and, a great communicator. But you get him in front of the family and that grief of, just kind of internalizing that grief, he really, really struggles. So,
yeah, and there's times where I'm on scene and I'll see the condition of a body, and the family always like it's often that people want to see their loved one one more time, and then I have to be the bearer of bad news, saying, "No, I'm sorry, you can't do that today." The funeral home will help coordinate that with you because one, funeral homes do amazing work. Now that I see the other side of what people look like after death, and they still can have an open casket, it amazes me the work that they can do. But I have to be the bearer of bad news a lot of the time where to say, no, I can't allow you to see them before they leave. The funeral home will set up a time for you to be able to do that. Just
yeah,
because I see the body and I wouldn't want to see my loved one that way. And I know that they're going to be very upset with me when I tell them they can't. And I have no problem being the bad guy. But I can't tell them I'm doing this because it's the right thing for you. I'm doing this because this is the way it needs to be.
this is the way it needs to be. Yeah, and I think they don't realize what a kindness that really is, because and I've had that conversation with people after, traumas and, when I worked in a trauma center where I was like, you don't wanna see him right now. Like,
No.
do that later. Like,
Yeah.
don't let this be the last and lasting memory of this person, because that's not nobody wants that.
Yeah.
So,
And we a lot of the time, like one of the hardest part of doing it is when we're doing our interviews, we don't want them to reminisce. We don't want them to bring up memories and think about their loved one because that can really derail our investigation. And
yeah,
again, we're trying to stay neutral as much as we can. We're not trying to play the role of the chaplain or the advocate that come to those scenes. So it's always hard because I don't want them to bring up memories because I don't want them to lose their track of what they're telling me. I want to obtain my information. Then I'm gonna have to tell them, oh, also I can't allow you to see them right now. And then that's as a nurse, the time I will know, like, now I'm going to allow them to say what they need to say in this moment because I've gathered my information. I've told them what they can and cannot do. And now I'm just going to
yeah,
let them talk because now's the time they need to.
yeah, very good. How interesting. What a delicate balance to try to straddle and try to make sure to meet those needs and try to keep the family as untraumatized as you possibly can.
Yeah. And
So,
then there's the whole other side of families that don't get along and then the pointing the fingers on scene and all of that. That's a whole nother avenue. That could be a full hour-long discussion.
Oh, yeah. And what do you do? So with this two very stressful jobs and very, potentially emotionally draining jobs, what do you do to decompress or to make sure that you're well and that you're good and you're not, getting affected by your day to day?
My biggest thing is just spending time with my family. I mean, that's why I never went into forensic science originally, because my family was in Nebraska. I didn't want to move away because we do so much together. So I spend a lot of time with my family. I'm the youngest of 4 kids. We all live in our Omaha area, so we spend a lot of times at my parents' house on the weekends, hanging out as a family. I have quite a few nieces and nephews, so that's been fun as they've started to grow up. There's some new babies in the family, so just
Sure.
spending time with family, that's the biggest thing.
That's awesome.
And they don't want to hear about my job, so it's easy for me to set it aside when I'm around that. Absolutely.
Well, very cool. Is there anything else I should have asked you that I didn't?
Not that I can really think of. I always tell people, if it's something that interests you, just look it up and try to get in the shadow wherever you can. I encourage autopsy labs, look at some programs, get the training. Even if you don't end up working as a death investigator, it's going to help you in your role as a nurse. So you're going to identify things that you didn't think to report to a medical examiner or coroner. You're like, this is weird. I'm going to call them and report it. And then you'll know if it's successful, because they either will or they won't send an investigator to the scene. So even if you don't become a death investigator, it's great to learn.
Yeah. Oh my gosh, I would love to do some training like that here. That'd be super cool.
Yeah.
So I'd be all into that. I think that'd be fascinating. So, uh, well, cool. I really appreciate you taking the time to do this with me. I appreciate you
Absolutely.
taking
No
the time to
problem. I
have this
love talking about
conversation.
it.
This is awesome. This has been super fascinating, and what an interesting specialty of a specialty, So
Yeah.
that's cool. That's why when you chimed in and you mentioned that, I was like, "Ooh, I'm gonna reach out to him."
I appreciate it. I love talking about it. I love trying to expand the specialty. I think it will just grow more and more. I think there's definitely getting more appreciation to having healthcare providers assist in the work. So I anticipate there being more opportunities in this type of nursing in the future. So I appreciate the opportunity getting to come on here and talk about it.
Hey, everybody, I hope you enjoyed this episode with my friend Kalen. Don't forget to follow him on social. He is at the forensic_merce. I'll leave a link in the show notes so you can find him. He really does post some interesting stuff, and a great person to follow. And don't forget to follow me on social media, Facebook, Instagram, all the places. I'm there. Till next time, we'll see you soon. Bye.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.